Welcome to the Institute of Medicine of Chicago. Hello, my name is Pat Meriwether Argus, and I'm a member of the Board of Governors of the Institute of Medicine of Chicago and co-chair of the IOMC Program Committee. In addition, I'm the Executive Director of Project Patient Care. It's my pleasure to welcome you today. Today's session is addressing the health disparities that are occurring within today's treatment and management of chronic kidney disease. This is a very important topic and impacting many people in the Chicago area. In Chicago, dialysis treatment programs treat approximately 60% of the patients are Black, and yet Black persons only make up 29% of the Chicago population. Chronic kidney disease can be detected early on through screening of patients routinely and with a focus on patients with diabetes or hypertension. While many patients are diagnosed too late and progress to having to rely on dialysis, many Black patients are unaware of organ transplant options and are disproportionately not waitlisted on the organ transplantation list. The National Academy of Sciences, Engineering, and Medicine recently released a study of recommendations for organ transplants. The extensive body of work is found in a book, Realizing the Promise of Equity in the Organ Transplantation System, and will be highlighted by Dr. Ken Kizer, Chair of the NASEM Organ Transplant Group, as well as Dennis Wagner, a member of the NASEM Committee on Organ Transplants. The objectives today for our session are obtain greater awareness of the impact of chronic kidney disease on people undergoing dialysis or organ transplants, be able to strategically address the disparities that have occurred in organ transplants, and implement changes to address health equity in kidney transplants. Today's agenda includes a discussion, a Q&A period, and updates on the future programs and speakers. It is our pleasure to welcome our three speakers today. I will be brief with our introductions because their background goes on for pages and pages, and to allow time for our very full and detailed presentation today. The full bios of today's outstanding speakers can be found on the IOMC event page of the website. We are pleased to welcome Dr. Ken Kizer, Chair of the NASEM Organ Committee, Chief Healthcare Transformation Officer, and Senior Executive Vice President. Dr. Kizer currently serves as a Vice President in Research, and he has been elected to both the National Academy of Medicine, the National Academy of Public Administration. Dr. Kizer is a highly experienced physician executive whose diverse professional experience includes senior leadership positions in the public and private sectors, academia, and philanthropy. And I've known Ken Kizer since his work with the VA, and I have to tell you, his background and what he has accomplished is truly amazing. And I think one thing to touch upon is also his interest in organ donations, because his wife is a double transplant of kidney and pancreas. And again, just a personal experience really is also a driving factor. Also joining us today is Dennis Wagner, a member of the NASEM Organ Committee, Principal and Managing Director for YES and Leadership. Dennis has served as the Principal and Managing Director for YES and Leadership since October of 2020. In this capacity, he has served as a speaker and session leader at in-person and online events for a wide array of organizations, such as the Iowa Health Collaborative, the Gift of Life Institute for Organ Donation and Transplantation, and the Association of Procurement Organizations, the National Association of State Pharmacy Associations, the University of Southern California School of Pharmacy, and others. And also important to many people on this conference listening in is many of you know Dennis as being one of the champions for quality and patient safety with the Centers for Medicare and Medicaid Services and heading up their quality area. A special guest speaker is Precious McCollin. Precious is a two-time kidney transplant recipient. She was diagnosed with kidney disease in 2010, receiving her first kidney and pancreas transplant the same year. The kidney failed after 7 months. She received in-center hemodialysis for 8 years, during which time she started her patient advocacy journey. She was instrumental in many interventions being put in place, not only at the center that she was at, but also in the state she was at and the nation. So again, a wonderful resource. She's highly involved in many committees dedicated to improving the process and experience for patients with CKD. Precious earned a Bachelor of Science in Criminal Justice in 2005 and a Master of Science in Human Behavior in 2018 while she was on dialysis. She is also a PhD candidate at this time. She received her second transplant in April 2019, and she diligently advocates for improved patient and family engagement, health literacy, and health equity. On behalf of the Board of Governors, it's my pleasure to warmly welcome everyone today. We are honored with your overall support of IOMC. The overall attendance at these virtual sessions has surpassed over 1,000 attendees in the past year. We are thrilled with the overall support. Please feel free to share your ideas on other topics you would like IOMC to cover. If you are visiting us for the first time, we conduct monthly virtual sessions, except during the summer months of July and August. In the fall, we expect to begin our work groups for fellows only. Please stay tuned for more information on how to become involved with IOMC as a fellow. If you are not a fellow and would like more information on membership, please contact Deborah Hodges, Association Manager and Program Manager at iomcstaff@iomc.org. IOMC is celebrating our 106th year, and in June, we will have reached our 107th year as an organization. IOMC is an independent, not-for-profit organization of distinguished leaders in the health field who collaborate to improve the health of the public. We are proud to draw upon the diverse membership and other regional leaders to address critical issues. IOMC cordially invites you to our upcoming IOMC Health Network celebration on June 30th at the venue 610. Please look for more details soon and register. There will be limited attendance at this event, so please register early. I would now like to turn the program over to a good friend and a person that I met several years ago and have just been inspired by her presentation and what she has accomplished. Precious, the floor is all yours.
All right, thank you, Pat. Hello, everyone. At the age of 9, I was diagnosed with type 1 diabetes. And in 2010, at the age of 27, I was diagnosed with end-stage kidney disease and did in-center hemodialysis treatments to survive. Receiving dialysis treatments was challenging due to the low health literacy about kidney disease. I didn't know the questions to ask, and I didn't know how to be engaged with my health care. Basically, I was still shocked that I had crashed into dialysis. And on top of that, I was so young, had just married my college sweetheart, and later had given birth to a handsome baby boy. Life was getting started for me, and kidney disease took over in a blink of an eye. I was fortunate to have a nephrologist approach me about kidney and pancreas transplantation. The referral and evaluation process went fast for me, and I only had to do in-center hemodialysis for 4 months before I was called to receive a transplant. Life was good and everything was looking up for me until 7 months after my transplant. My one and only child, my son, passed away unexpectedly at the age of 2. My husband and I were devastated, but we decided to donate our son's organs to give others a second chance at life. The day after my son's passing, I got very sick and was hospitalized and treated for severe nausea and vomiting. After I was stabilized while still in the hospital, my husband and I planned our son's funeral services. I had no idea what was in store for me next. 4 days after my son's passing, I began to experience pain in the organ transplanted area. The hospital physicians ran tests and determined that I needed immediately to be transported to the operating room. Unfortunately, the transplanted kidney and pancreas had to be removed, and I woke up in ICU connected to a dialysis machine. The medical trauma that I experienced took a toll on me mentally and physically. Having to return to a dialysis facility for care and losing my precious son made it hard for me to engage with my care. I was in and out of the hospital. One day, I had a dream about my son while I was hospitalized. I dreamed he came into the room and kissed me. And that's when I decided to live. And I decided that I would not let kidney disease defeat me. So I got involved with my care, and my nephrologist saw the change in me and talked to me about relisting for a second kidney transplant, which I received in 2019. I waited 8 long years to receive it, but while I wait, I became more eager to learn about kidney health and help patients struggling to adjust living with kidney disease. I have had the opportunity to advocate for my kidney peers around the country and have experienced disparities in kidney care. Take kidney transplantation. Many patients do not know that they can possibly list for a kidney transplant before starting dialysis. Also, African American kidney patients are uninformed about the utilization of the estimated glomerular filtration rate, also known as EGFR. Studies have shown that the Black race variable in a commonly used EGFR formula increases Black patients' EGFR by as much as 16%. However, there are potential consequences of using the Black race coefficient, which includes delayed referral for transplant and qualifying for wait time. Also, impede timely chronic kidney disease management that contributes to worse outcomes. Finally, I challenge you all today to identify social determinants of health and areas of low health literacy within the populations you serve to effectively address health disparities to improve equity for better health outcomes. Thank you.
Well, great. Thank you, Pat, and thank you for those kind words. And thank you, Precious, for those very personal and moving reflections on your experience. Having had my former wife, now deceased, having been through the transplant process 3 different times, I can relate to many of the experiences that you've had. Well, good afternoon, everyone. It's great to be with you and to share some of the findings and recommendations that are contained in the recently released National Academy's report on reforming the nation's organ transplantation system. The book is now available, hot off the press in final published form. I'm especially pleased to be joined in making these comments by my colleague and friend, Dennis Wagner, who was a member of the study committee. Dennis, if you want to say hello before we move on.
Yeah, very good. So thank you, Ken. And I just want to thank both Precious, Pat, and IOMC for having us here today. I think that this is very important work that really significantly impacts the lives of patients like Precious. And there are many things that we can do in our work to generate improvements. And Dr. Kizer and I will cover many of those as part of this presentation. It's good to be here. Thank you, Ken.
Great, thanks, Dennis. Could we have the next slide? Actually, let's just move on to the next one. So in the time that we have this afternoon, the next 25 or 30 minutes, we want to do three things as noted here, but we want to focus especially on what we can do to better deal with the inequities that exist in the system. So I'm going to make some very brief comments about the organ transplant system, which is probably like taking coal to Newcastle for this audience. I want to present some details about how the NASEM study was done, and then mainly talk about some of the conclusions and recommendations in the report, focusing particularly on those dealing with disparities. I would make a couple of prefatory comments before launching into the other slides. First, there's a lot in the report that we will not be discussing today simply because we just don't have time to do it. Secondly, the significant amount of information contained on the slides, which I'm not going to discuss, but wanted to make available to folks if they look at the slides when there's more time to do so. And third, I would just say that Dennis and I are going to do a bit of a tag team and go back and forth, and he's going to jump in whenever the mood strikes him, and otherwise as we move along. So let me just start. I said I wanted to make a few comments about the organ transplant system. So with this and the next slide, I will do that. But as I think many of you know, it's a very complex system that involves a lot of moving parts, from the more than 250 transplant centers, the 57 organ procurement organizations, all the donor hospitals, both state and federal government regulators, the thousands and thousands of healthcare professionals, lots of advocacy organizations, and of course, the hundreds of thousands of patients and potential donors. So lots of moving parts. Since the first successful kidney transplant was done in 1954, more than 1 million transplants have been performed in the United States, and organ transplantation is increasingly recognized as a mainstay treatment for multiple different types of end-stage organ failure. Now, 2021 was a record year for the number of transplants that were done in the United States, with more than 41,000 being done. But I would also call out that it was also a record year for the number of donated organs that were not used. And we'll come back to that later. More than 6,000 donated kidneys were not used, and probably 5,000 of those could have been used to save a life. Other points I could make, perhaps the last thing I would call out is that in our very divided American society right now, organ transplantation, organ donors enjoys amazingly broad support, with more than 90% of Americans supporting organ donation. So there's a lot of things that we confronted during the course of our study, and this slide calls out some of the common perceptions about the system and the reality. I'm not going to take the time to go through each of these things. This is one that you can refer back to later, but I would just summarize this slide by saying many people who are waitlisted for an organ get offers, sometimes very early or very in the process, very soon after being listed, but they never know about it. I would also say that contrary to common perceptions, many good organs, many good kidneys in particular, are not transplanted or used. And we'll talk a little bit more about this as we move through some of the other slides. So next slide. So let me shift gears and do the second thing we talked about. Let's say a few things about how this National Academy study was done. Next. So the study was done per the request and direction of the Congress. And we had a broad charge to look at a number of specific things, kind of summarized here, in that we were asked to take a broad look at the organ transplantation system and basically what could we do better, particularly with regard to making the system more equitable. So let me move on to the next slide. So as I said, it was the study was done at the request of the Congress. It was sponsored by the National Institutes of Health and the National Institutes of Allergy and Infectious Disease in particular. We released the study after about 18 months working on it at the end of February. Importantly, we were asked to focus only on deceased organ donation, not on living donation, nor on issues related to tissue use. And while we considered organ transplantation broadly, and the report focuses a lot on all types of organ transplants, there was a particular focus on kidneys, since about 85% of people who are on the waiting list are there for a kidney. We really, our lens for looking at things was the patient and how the system could put the patient at the center of the universe and really be the focus of systems improvement. And I would be remiss if I didn't also call out that we recognize that the organ transplant system does a lot of really good things and saves a lot of lives every year, and is composed of thousands of very hardworking and committed people. But our charge was to look at what the problems were and how the system could be made better. So our report, while we recognize the good things that the system does, we really focus on the problems and making improvements. And I think that's an important context to keep in mind as we go forward. Next slide. Just a list of the people who were composed. I was fortunate and blessed to have a particularly talented and diverse and very experienced group of folks to work on this issue with me. Next slide. As you would expect from a National Academy's report, it was very data-driven. We reviewed the scientific literature and essentially any publicly available information we could get our hands on. We commissioned several papers to address particular issues or questions that we had. We gathered quite a bit of public input, had 4 different public meetings where we heard from folks, including Precious. And we received written comments from a wide array of stakeholders. We deliberated on this over a period of about 18 months or so. We had lots of full committee meetings and innumerable smaller group meetings. Because of COVID, the entire study was done virtually. It was a new experience for me, and I think for the rest of the committee, doing something like this entirely virtually, but it worked out quite well, I think. Dennis, anything you want to chime in here before we move on to talk about some of the specific conclusions and recommendations?
No, thank you, Ken. I'd say charge forward. Yep. All
right, so let's move forward. As I said at the outset, we're going to go through things relatively quickly, making hopefully some key points as we go along. So the report and our conclusions and recommendations really kind of fell into 3 categories. One, the need to improve equity in the system, and some conclusions and recommendations specifically in that regard. Secondly, how can we use more donated organs? And third, how do we improve the overall system and its performance. We're going to focus particularly here on the equity side of things, but there's a robust list of conclusions and recommendations that deal with the other issues as well, some of which I will mention, but we're going to focus particularly on equity. Next slide. So I think one of the key conclusions from the study is that despite the good things that it does, the U.S. organ transplantation system is demonstrably inequitable. Certain groups of patients, as was alluded to earlier, whether they be persons of color, persons who are poor, females, olders, people with different disabilities or inheritable diseases, just don't receive organ transplants at the same rate that other groups do that have comparable medical need. Some of the specific things that were observed that we need to focus on with regard to improving equity is that currently the oversight of the system doesn't begin until a person with end-stage organ failure is waitlisted for a transplant. But many of the people who would benefit from an organ transplant have limited and inequitable access to transplant evaluation. Many of the inequities in the system are upstream to being waitlisted. And we have some specific things that we think need to be done in that regard. Persons of color, as was already noted, have a significantly lower chance of being referred for a kidney transplant prior to beginning dialysis. And the converse, if you are white, have greater health literacy, have private health insurance, then you're more likely to have access to a kidney transplant than persons who aren't similarly advantaged. Next slide. So one of the key recommendations with regard to improving equity is simply that the Department of Health and Human Services should be tasked and charged and held accountable for achieving equity in the organ transplantation system within the next 5 years. We debated a lot about what was the right amount of time that they should be given to achieve equity. And while 5 years may be ambitious or aggressive, it's also doable and could be accomplished. And I think that's an important point. We think that within the next year or so, the strategy to achieve equity should be promulgated. We also, and importantly, believe that HHS should extend its regulatory oversight to the point at which a patient reaches end-stage organ failure, not when they are placed on the transplant system. Oversight needs to begin earlier, and it also needs to extend beyond the 1-year transplant or post-transplant time frame. And there's a lot of things that it could also do as far as improving communication between waitlisted candidates for organs that currently aren't being done. Dennis, comments you want to add?
Yeah, I think a couple things that I would say. One is that I am pleased with the very active interest that folks at the Centers for Medicare and Medicaid Services and at the Health Resources and Services Administration have given to this report. I think they're considering it very carefully and looking at things that they can do, and there are many. As someone who spent 10 years at CMS, I think the one other thing I would say is that it is that a kidney transplantation, and 85% of the transplants are in the kidney, have to do with kidneys. In the kidney space, not only are the lives of patients substantially improved when they get a kidney transplant over being on dialysis, but it actually saves the Medicare and the taxpayer money to get more of those kidneys transplanted. So there's a tremendous opportunity to close the gap on disparities, particularly in kidney transplant. Medicare pays for the vast majority of kidney transplants, so we don't have the same issues with funding. There still are issues, make no mistake, but the vast majority of kidney transplants are paid for by Medicare. And if we go upstream and start doing a better job of referring patients, evaluating those that are referred, and then waitlisting those that are evaluated, we can close the gap, I think, on a lot of the disparities that you've highlighted here, Ken, and that Pat mentioned right at the beginning of the program. Thanks, and back to you, Ken.
Yeah, I mean, this is one of those infrequent win-wins for everybody. So it's really hard to understand why we wouldn't be charging ahead full speed to implement the needed changes. Next slide. So we made some recommendations specifically with regard to OPTN accelerating the continuous distribution allocation framework, moving it up from the current timeline. And I will defer you to the report for specifics in that regard. Likewise, without going into great detail, I would say we also recommended that OPTN should eliminate the pre-dialysis waiting time credit for the kidney allocation system. We realize that this creates some logistical transitional issues which are addressed in the report, but they are certainly something that could be done. Next slide. Also made a number of recommendations specifically with regard to how we could resolve some of the inequities in the system by changing the different organ allocation algorithms. And I would defer you to the report on many of the specifics and the technical issues involved with the different types of organs. The one point I would just call out here has to do with kidney transplants and the recommendation for eliminating race in calculating kidney function, the EGFR that Precious mentioned earlier. And again, there are some logistical things that need to be done in that regard. But insofar as race really doesn't have a biological basis, there really is no reason to continue that. I'm pleased to see that some health systems, like the VA, have already implemented this, but there are a lot of others that need to move forward in this regard, and the transplant system per se needs to specifically address this issue. So before we move on to using more donated organs, Dennis, did you want to add anything to what was said with regard to equity?
Just that there is a tremendous opportunity to close the gap here. This is not a problem that can't be solved. This is a problem with solutions. And there are actions that we can take immediately to begin to close that gap. Just for instance, transplant centers can start assessing of the patients that are referred, what fraction of those patients that are referred are evaluated. Of those who are evaluated, what fraction of those patients that are evaluated are being listed? And when we start tracking that data and looking at the underlying burden of disease in the populations, we can get a handle on where the gaps exist on equity, and we can take actions to close those gaps. This isn't something that we have to wait exclusively for the government to do. This is something that can happen with OPOs, with transplant centers, and others who are part of the system. Thanks, Ken.
All right, lots to do. This is not an insolvable problem. We just have to have the will to move forward and implement the things that we know. So let me shift gears to the second bucket, if you will, of conclusions and recommendations in the report, which had to do with simply that we're not using all the organs that we could. And while this is perhaps most glaring or most glaring problem in the area of kidneys, it also applies to other types of transplants as well. And quite simply, there's just too many donated organs aren't transplanted each year. And in 2021, as I already noted, was a record year in this regard, in that 6,427 deceased donor kidneys were not utilized, and thousands of those could have been utilized to save lives. It's just too easy for transplant centers to decline usable organs. There's not enough transparency and accountability for the decision-making in this regard. It's particularly stunning, I guess is the right word, that the non-use of organs is so much higher on weekends than other days of the week. And this just simply is a condition that we should not allow or tolerate to continue going forward. Next slide. I just want to come back to this non-use of organs, particularly with regard to kidneys. It wasn't that 2021 was an outlier and that had something to do with COVID or some other circumstance. If we look back, the non-use rate has been steadily rising for more than the past 20 years. This is just something that has to be dealt with. I think the rate of non-use has gotten to the point where it's really unconscionable at this point. Next slide. Again, the common misperceptions that only bad organs are discarded. This slide from the report looks specifically at the organs that were transplanted and those that were discarded based on their KDPI. And as you can see, there is a large degree of overlap, which in essence just means that a lot of good kidneys, very transplantable, usable kidneys, are not being transplanted. Next slide. Again, one of the figures from the report where we look specifically at the probability of receiving a kidney transplant within 3 years of being waitlisted. And each of those horizontal lines here represents a donor service area, and the little blips, triangles, and other figures on there represents the performance of transplant centers within there. And the main point or the takeaway from this is simply that there is a large degree of variability, even with the same donor service area. And regrettably, that degree of variability is just simply not understood. It's not clear why this is occurring. Dennis, do you want to weigh in?
Yeah, thank you. I would just say that, I have worked closely in this field dating back to 2002. And I always carried what I think is a common misperception that how quickly a patient gets transplanted has a lot to do with geography, it has to do with where you live, and particularly with the ability of the organ procurement organization to secure commitments for donation from eligible donors and their families. And what this slide shows us is that lots of the variation, perhaps even most of the variation, has to do with the offer acceptance practices and other practices of transplant centers. And where you get listed as a patient, which transplant centers you get listed, or centers you get listed with, has a tremendous, not a small, a tremendous impact on the probability of getting a life-saving transplant within 3 years. And I know that you're going to have another slide later, Ken, that's going to make this point, but I'm going to just say it out loud here. The variation in the probability of getting a transplant within 3 years, if you're a patient, is from 4%, a 4% chance that you get transplanted in one center, that's at the lower end, all the way up to a 65% chance that you get transplanted within 3 years in another center. And that has less to do with geography than it does with the practices of the transplant centers. Patients need to know this. This is one of the things that I think we need to begin to address with system and method. We need to begin to use the best practices of those high-performing transplant centers that are accepting and successfully using organs for their patients. And that's something that we can do now. We don't have to wait on that. And it's critically important for waiting patients like Precious and others that we improve the performance across the system. Thanks, Ken. Back to you.
All right. Yeah. Next slide. And I just looked at the clock here, so I'm actually going to shift into a little bit higher gear. We specifically recommended that the OPTN should make it easier for transplant centers to say yes, and had a number of specific and actionable recommendations in that regard, which I will refer you to the report to go into more detail. Next slide. So the third category of recommendations in the report has to do with just overall improvement that's needed in the system and things that could be done to improve the overall performance of the system. The point which has already been alluded to, and I won't dwell on here, is simply that there is tremendous variation within the system that is simply not explainable, and that we don't understand why it is. I mean, there are some observations that can be made, but it's often very hard to understand the degree of variability that exists. And again, we make a number of specific recommendations about what can be done in that regard. Next slide. Dennis already alluded to perhaps the main point on this is simply the wide degree of variability in the likelihood of getting a kidney transplant within 3 years once one is waitlisted. The other point I would come back to is this non-use of organs is higher on the weekends. This is not a unique phenomena to organ transplantation. We see it in other areas of medicine and surgery in particular. But this is, again, a very soluble problem. There's a robust body of knowledge about how to deal with this. Dennis, I know you're quite familiar with this. I don't know if you want to weigh in on a couple points here.
I think I would just say very quickly, looking at time and also consulting the chat, that data on transplant center performance, on OPO performance is available. Thinking of getting listed to consult that website. As regards some of these problems being solvable, like the greater use of organs on the weekend, these are problems that are a function of hospital management and hospital flow, which also have solutions. There are known best practices that have been successfully used by many large hospitals across the United States and North America for managing hospital flow. And if hospitals use those already proven and established methods, we can reduce these higher discard rates that are occurring on the weekends. And this will improve care for patients, not only with transplant, but across the board, which, as you know, Ken, it appears multiple times in different ways throughout the report in terms of that particular recommendation that hospitals take action on this, that CMS take action on this, and others. Thanks, Ken.
All right, the only other thing I would just call attention to, and it's discussed in some detail in the report, is this donor care units. That's perhaps not a topic of as much interest here, but there are 11 OPOs that have them. The others need to put them in place, and again, we specifically make some recommendations in that regard. Next slide. We talk in the report about the need for HHS to develop some national goals and some performance goals, focusing particularly on the performance of the highest performing 5 or 10% of participants in the system. This is, again, not something that is unique to transplant, but the fact that 5 or 10% of organizations are performing at this level means that the others can as well. We need to focus on what they're doing, what are their best practices to overall improve the overall performance of the system. I'm just going to go to, in the interest of time, go to the next slide. So this, again, I don't think we need to dwell on it, on this, but we need standardized performance metrics and metrics that cover a number of things that currently aren't addressed. While there is significant information available, we certainly don't understand what's happening upstream and where many of the inequities occur. And there are some specific things that we can do in that regard. We need to embed continuous quality improvement really in the fabric of the organization and make this an ongoing and continuous process. I know, Dennis, if you want to add anything to this.
I would just say very quickly that having had the accountability for leading the quality improvement portfolio at CMS for more than 5 years, that when we set national goals like the ones recommended in this report and then go to work in earnest seeking to achieve them, we have had remarkable success. We have been able to dramatically improve hospital patient safety. In the early 2000s, we've been able to dramatically improve organ donation across the United States. So again, this really is a matter of identifying the best practices of the highest performers in the system and then spreading them with system and method. And we've got a track record of success in doing this. And I think we can tackle many of these problems successfully as well.
So let me just try to wrap this up, and then we have, I think, one slide on what we could do tomorrow. So where we would like to be from where we were last year in 2021, in 5 years from now, we would like the system to go from being demonstrably inequitable to equitable. That's an achievable goal. Instead of patients being unaware of the organs, we want patients to know about the organ offers and the declines, and shared decision-making is one of the strategies that could be utilized to get there. Instead of going from last year's 25% of deceased donor kidneys not being used, we think that rate should be brought down to less than 5%. Instead of having the inexplicable wide variation that exists, we need to reduce that and be able to understand clearly when variation is occurring and why it's occurring. We need more robust, standardized consensus metrics. All OPOs need to have donor care units. And while we haven't really talked about it here, the report talks about the IT systems and the fact that we need a more state-of-the-art, forward-looking IT system to support the overall transplant system. Let's go to the next slide. So, and actually, I'm going to throw this back to you, Dennis. What could you do tomorrow? What are the things that OPOs, transplant centers, donor hospitals could begin action on essentially immediately? Next slide.
Very good. Thank you, Ken. Yeah, so this, there are many recommendations in this report that are directed to HRSA, to CMS, to the Organ Procurement Transplant Network, but there are many recommendations in here that are directed to transplant centers, to OPOs, that can be acted on right away. And you see a list of 5 examples here. There are more. Ken and I actually have 3 slides of these, but time is limited. We can begin developing locally specific action plans to increase donation, both donation and transplantation among minority and underserved populations. This means looking at our data. If you're the Gift of Hope OPO, look at your data, look at the opportunities for improvement, look at folks across the United States that have done better and set new goals. Same with transplant centers in Chicagoland and elsewhere. Identify the top the centers in the United States that are accepting and using successfully organs that are being declined elsewhere. Study their practices. They know what it is that they're doing at the Miami Transplant Institute, at Mayo Clinic of Arizona. They know the practices that they're using to accept more organs and then to use those successfully. And those are practices that can be implemented in all parts of the United States. This business of making patients aware when organs are declined on their behalf. And the report recommends that there be periodic communication back to patients who are on the wait list, informing them, every 3 to 4 months, for instance, of organs that were declined on their behalf. Most patients are unaware that their centers are getting organ offers and that they're being declined. We believe that first, it's important to be transparent with patients about this. It's the right thing to do, but that patients' needs and desires about the kinds of organs that they want to take change over time. Taking this action of having some kind of a regular system of closing the loops with waitlisted patients by their transplant centers is a recommendation that could be acted on right away. We talked earlier about hospital flow and the opportunities to improve flow in hospitals using known best practices so that organs can get transplanted 24/7, 7 days a week. There are best practices that are known on that. And these are things that transplant centers and large hospitals can implement right away. They don't need CMS or somebody else to tell them to do so. And then to begin assessing the net survival benefit of kidneys offered compared to staying on dialysis. I don't know if we mentioned specifically, Ken, but there were 4 transplant surgeons who served on our committee. And so often they talked about as transplant surgeons, when you get organ offers and you think, well, the organ's not as good as I'd like. I'm getting an offer for this patient now. Maybe I'll wait for a better organ. And then a better organ doesn't come, or it doesn't come in enough time for that patient to receive it. When transplant surgeons look at organ offers, the appropriate consideration is this organ better than staying on dialysis for this patient? You know, what's going to produce the better outcome? And that's an assessment of net survival benefit, and the kinds of things that transplant surgeons don't have to wait for someone to say they should do this. This is the kind of thing that we can begin to take action on right away. So that's just kind of the short list of 5 out of 15. I think, Ken, I could actually provide the slides with a longer list if Pat and the IOMC is interested in sending them. Thank you.
All right, so we are at time. We've used up our allotted time and a little bit more. So if we go to the next slide, which I think basically is opening the door to whatever time we might have for questions and discussion about any of the things that have been talked about in the last 35 minutes or so. Next slide, I think, is the Q&A one.
Yep.
So, Pat?
There are a number of questions. Thank you so much, Ken and Dennis and Precious. There are a number of questions that have come in through the chat box, and I'm going to start with some. Are some donated organs rejected during the weekdays as well? Is it just weekends or weekdays as well?
I'll go ahead and jump in, Ken, on this one. Yes, so organs are declined. Offered organs are declined all 7 days of the week. So that happens every day of the week that organs are declined. The rate of decline and the rate of discard, organs that are declined so many times that they're eventually discarded, is higher on the weekends, but there are still declines and discards that occur 7 days of the week. The reason that's most often given for that is the quality of the organ. That the offer is made and the surgeon or the transplant center declines it because of the quality of the organ. Now, the important thing about that, though, is that most of the organs that are declined are ultimately transplanted somewhere else, which is an indication that organ quality is not really the ultimate issue here, even though that is the reason that is most often given. Just as an example, when kidneys are offered to the first patient and the surgeon that kidney is offered to, they're accepted. That first offer is accepted only 8% of the time, but 75% of the kidneys are ultimately used. So that tells you right away that organ quality is really not the key or the only factor, even though that is most often the reason that's given.
So we're in Chicago and we have several transplant centers. And so if somebody wanted to go on a list, do they have to, register at each center? And then are there variations in Chicago on the transplants, the percent of transplants?
Well, I didn't specifically review the Chicago data, but based on what we've seen elsewhere, I'm sure there is substantial variation across the different centers within Chicago, because that's what we see every place else where we look at it. There's no reason to think that Chicago is necessarily different.
And so in a region, is there a standardized set of criteria that they use in terms of getting listed, or is it all up to the transplant centers? Yeah, so I'll just say that the listing practices vary significantly from center to center. These practices are not standardized. A patient that seeks to get listed at one center may be told that their BMI is too great to be listed, whereas if they went to another center, they may very well be able to get listed. So there is not standardization of the listing practices. And if a patient gets listed at a center, they are listed at that center. They are not listed regionally or anywhere else. They are listed with that center.
And as I think Precious mentioned previously, I can't remember if it was in this call or in a prep call, patients often get listed at multiple centers, which is one way to increase the likelihood of being transplanted more quickly.
I have to say, I think most patients don't understand this, and so certainly families don't understand the process. So again, I just think more transparency is needed, as well as I think most people would like to see the transparency of the percent of organs that are being utilized and transplanted. Now there's
let me just throw in
a
Okay. Editorial comment there. Having been through this process with my wife multiple times, and I would consider myself probably a pretty sophisticated healthcare user. My wife had an advanced degree, and she was likewise. Understanding the listing process created many mysteries for us.
Okay. And that's, again, it shouldn't be that way. It's a way too of sort of what I'd like to say discriminating, because people don't know what they don't know. Okay, I want to ask a question. This is taking it to, as I said, a macro level, a little bit higher level, is what has been the response from Congress to your recommendations? And do you really need legislation to make any of these changes?
Well, Congress has listened. We have provided multiple briefings to different congressional committees and staff. They seem to be receptive, and I would underscore what Dennis said also about CMS and HRSA being extremely receptive to what has been put forth. So far, and recognizing we're only a couple months out, that we haven't seen any tangible actions other than, for example, the HRSA, when they released their recent RFI, did make specific reference to the report and addressing a number of the issues that were called out in the report. There is much, I'm shifting gears here slightly, there is much that could be done without legislation, as we've already alluded to some of those things, and you don't have to wait. I mean, these are things that literally you could start doing tomorrow. And there are some things that do require congressional action. So it's a mixed bag. And particularly, while we didn't touch on it in this report, there are some things that relate to payment that do require Congress to support CMS and doing some of the things that CMS would like to do, but it requires congressional action. So mixed bag, but an awful lot doesn't require Congress to do anything.
And do you have champions in Congress for any of the recommendations?
Well, we know that there's
Yeah.
we know that there's a lot of congressional interest in the overall topic of organ transplantation. And we would be happy to work with any member who would like to become our champion and the champion of patients who need transplants.
Okay. And then another question too is, you know, we know that in healthcare, there's accreditation for labs, for hospitals, for nursing homes, for home health, and on and on. Is there any accreditation process for transplant centers? And if not, do you think that's possible in the future?
So I used to license and certify hospitals in California, but I'm going to ask Dennis if he wants to respond to that based on his experience with CMS in particular.
Yeah, I would just say that transplant centers are surveyed by CMS, so they go through a regular survey process with the agency, and the agency looks at all of the data related to their performance and the use of different practices and procedures that are expected in terms of the survey process. And transplant centers generally have to meet certain standards in order to get recertified as a transplant center through that survey process. I would say that that is probably the dominant system that's in place for ensuring transplant center performance. I will mention that CMS made a change in 2019 where the agency had previously looked at 1-year graft survival as the principal factor for assessing transplant center performance. And the agency discontinued the use of that measure in 2019, mainly because of concerns that it was causing transplant centers to not transplant organs that were very viable, that it was causing greater conservatism. You saw the chart that Ken presented with discard rates going up. And the agency expected that having changed that, the use of that measure, discontinuing it, that the discard rate would drop. And unfortunately, the discard rate has only grown since 2019, which is very sad. I think that looking at things like organ offer declines, the numbers of organs that are systematically used are the kinds of things that we perhaps need to shift attention to going forward.
I want to close with some guidance and advice from Precious, and also reflect on what you've heard, Precious, as someone who has gone through multiple kidney transplants, and what are your thoughts? What advice can you give to patients and families and caregivers, as well as to our distinguished Ken and Dennis, in terms of your reflections on what you've heard?
First of all, I would like to thank Dennis and Dr. Kizer for their work and their effort with this report. It is very valuable to people like myself. I would like to say that what I would encourage both patients and their family members to do is to get involved with their healthcare, ask questions, try to work with your healthcare providers as a team. Also, I would encourage healthcare professionals to be transparent with patients. Let them know, address their concerns. Also, determine and consider their issues and their concerns and things that may be deterring them from making viable healthcare choices. So that's what I will leave the audience with today, is to just get involved. Let's work together. Let's make a difference. We all need each other to make the healthcare system better.
Thank you. Thank you, Precious. And I know there's one more question in the Q&A box, and maybe if Dennis or Ken can respond to that. I want to thank you, Precious, Ken, and Dennis, for your thoughtful presentations and insights on what we can do not only nationally, but possibly what we can do in Chicago to improve the lives of chronic kidney patients, and also improve the transplant system, because everything I heard today shouts out that we definitely need to make some improvements. And again, this book is hot off the press, and it's called Realizing the Promise of Equity in the Organ Transplantation System. So I urge everyone to reflect on what you've heard today and help move into action. There's many action groups that are also, besides Ken and Dennis, there's also action groups that are very interested in advancing kidney donations and organ donations. And I know the National Kidney Foundation of Illinois is participating in this conference, this webinar today. And that's another group that you can reach out to as well for assistance. And as they said too, the more transparency we have, the more education of patients and families will make a difference in terms of pushing the system to a level that we really want and desire. I want to thank everyone for their insights and experience today that you've shared, and just remind everyone of the IOMC Healthcare Awards celebration on June 30th. It's the 107th anniversary, and it's going to be an early evening event, not a late night, and we hope to see you all there. And look for a survey link to provide feedback on today's presentation and share your ideas about future sessions that you would like to see at IOMC. Please follow us on LinkedIn, check out our blog, and also visit the IOMC website for more details. And you have the contact information from Ken and Dennis and Precious. And what we'll do is we'll also make sure that we get the information that Ken had mentioned, as well as the slides, out to all of you. Thank you for your participation, and we wish you well and good health. Thank you.